Go ahead.
Okay. So we're going to actually talk about blood pressure, and whatever is in this PowerPoint will be on the test for next week. Okay? Now, let's talk about some terminology. Pulse. What is pulse? Every time you're actually checking your pulse, what are you checking? You're actually checking the stretching and the recoiling of the arteries. So every time blood enters the artery, it stretches. Every time blood leaves, it comes back to its original shape. So a pulse is stretching and recoiling of the arteries. Now, blood pressure. What is blood pressure? So blood pressure is the force of blood against the arterial walls. Okay? So we have two components to a blood pressure, systole and diastole. Systole is the top number, it's a larger number, where diastole is the lower number and it's smaller. Okay? The normal range for systole is from 100 to 120 millimeters per mercury, where diastole, the lower number, is, or the normal range is 60 to 80 millimeters per mercury. Now, when I say systole, okay, in blood pressure terms, what does that mean? So it tells you when your heart is contracting and ejecting blood, because systole means contracting and ejection, correct? Mm-hmm. So when your heart is contracting and ejecting blood, what is the pressure in your peripheral arterial system? That's what it tells you. Diastole tells you when your heart is relaxed and filling with blood, what is the pressure in your peripheral arterial system? Okay. Any questions so far? Okay. Now, there's a way to calculate blood pressure. Not to calculate. Mean arterial pressure. So MAP means mean arterial pressure. So it's looking at the average pressure inside all of your peripheral arteries. So the formula to calculate that, there are a bunch of formulas. There's up to 8 or 9. The two I expect you to know are the ones that I have presented. So diastolic pressure plus pulse pressure divided by 3. That's one way to calculate MAP, mean arterial pressure. So that's diastolic pressure plus pulse pressure divided by 3. Okay? Another equation you can use is 2 times the diastolic pressure plus systolic pressure, that divided by 3. So 2 times diastolic pressure plus the systolic pressure divided by 3. Regardless which equation you use, it will give you the same answer. Now, what is pulse pressure? Any idea? Pulse pressure is the difference between your systolic and your diastolic. Okay? So, we have a systolic of 120, right? And you have a diastolic of 80, right? Usually our average blood pressure is 120 over 80. Okay? So how do you calculate the pulse pressure? So systolic pressure minus diastolic pressure gives you pulse pressure. So 120 minus 80 gives you what?
140.
Huh?
40.
40. So the pulse pressure would be 40. Okay? Does that make sense? What happened, Mel? Oh, okay. So 120 minus 80 gives you 40. So your 40 is the pulse pressure. Okay? Any questions so far? Move on. Now, why is it important to maintain your blood pressure? You guys always heard doctors saying, okay, your blood pressure is too high, we have to control it. Your blood pressure is too low, we have to control it. Why? What is the significance of that? As I've told you, everything always moves due to high to low, right? So if you don't have enough pressure, do you think blood is going to be flowing?
No.
No. So if blood is not flowing, are you receiving oxygen to your tissues?
No.
If you're not receiving oxygen, your tissue will start to die. Okay? So right here, no pressure, then you don't have any blood flow. If you don't have blood flow, your tissue experience hypoxia. Hypoxia is a drop in blood pressure. A drop in oxygen. due to hypoxia, which is drop in oxygen levels, your tissues will undergo necrosis, which is cell death. Okay, so your tissues will start dying. So this is very important, one reason why you need to make sure your blood pressure is normal. So this is a side effect of, or consequence of having low blood pressure. But what is a consequence of having high blood pressure? Why is high blood pressure dangerous as well? So if you have high blood pressure, you damage your arteries. If you damage your arteries, you damage your organ, and therefore you will start having problems. Imagine this is a new building. This is a very nice sturdy wall, okay? Let's say the building just got built. If I take a hammer and if I keep on hitting the wall, what's going to happen to this wall? It's going to break, right? It's going to have a hole, it's going to break. So imagine that with blood pressure. Imagine your arterial walls as this sturdy, nice wall, okay? Where that blood pressure, high blood pressure, is that hammer. It's constantly hitting the wall, and therefore it's going to damage the vessel wall, and in turn, your organ, and then you will start having organ failure. Make sense? So that's one consequence or one danger of having high blood pressure. What's another reason? High blood pressure leads to increased workload on the heart. So if you have high blood pressure, your heart has to work harder. If your heart has to work harder, then basically it's going to cause myocardial infarction, which is heart attack, or congestive heart failure, meaning your heart is just being pulled with blood. Now let me ask you, if you have high blood pressure, why is it an increased work on your heart? Any idea? You guys have the knowledge.
Because it has to have a consistent flow
No?
pressure.
So the heart will have to contract harder to get all the blood out.
Why does the heart have to contract harder?
Because there will be more
Because of the high
There's
blood
more
pressure.
So what does high blood pressure have to do with the heart contracting harder?
There's not enough volume.
So, if your blood pressure is 120 millimeters per mercury over 80, how much pressure must your left ventricle generate to open up your aortic valve? 121 at least, right? So now let's say somebody's blood pressure is 200 over 100 millimeters per mercury. How much pressure must your left ventricle generate? 201. So isn't that causing your muscles, your heart muscles to work harder, right? Because now instead of generating 121, it has to generate 201. So you are asking your heart to work harder, okay? And therefore, if your heart is working harder, what does it require? It's going to say, okay, fine, I'll work harder, but in turn, you have to give me something. Let's say you're at your work, and they tell you to work another shift. What are you going to ask? You're doing another shift. What are you going to ask in return?
More money.
Money. You're going to ask money, right? You're like, fine, I'll do another shift, but I want to get paid. So the heart is the same way. It's like, fine, I'll work harder, but you have to give me money. In sense of heart, what is the money? Oxygen.
Oxygen. Oh, okay, you're right.
Right? So the heart is like, I need oxygen. It's a cell. To work, it needs energy. And you guys know the importance of oxygen in energy production, right? You guys recall? Krebs cycle, intermediate step will not work without oxygen. So you don't have ATP being produced. So this is what congestive heart failure and myocardial infarction starts to occur. You're asking your heart to do a lot of work, but your heart cannot keep up because your body cannot supply that oxygen demand. So your heart either goes into heart failure, which is myocardial infarction, or it cannot push that blood out because it cannot open the aortic valve, which is congestive heart failure. It just starts to pull in there. So this is why high blood pressure is very dangerous. Okay? Any questions so far?
Would that also lead to increase in the size of the heart too?
Yes,
Yeah.
of course. So now because you have more blood, so imagine a balloon. If you keep on putting air in it, what happens to the size of the balloon? It expands. So that's what happens to the heart too. It dilates. Another thing, because it has to actually pump more blood, so it needs more muscle, it actually increases in size. It actually causes the cells to become bigger and even increase the number of cells, which you will learn in patho, hypertrophy and hyperplasia occurs. Now, what detects blood pressure? So we have baroreceptors, and the function of these baroreceptors is to detect the blood pressure. Where are they located? They're located in the carotid artery, aortic arch, and the kidney. Okay? Now, let's say our blood pressure drops, and our kidneys detect there's a drop in blood pressure. What does the kidney release in return?
Renin.
Perfect. So it releases renin, causing the renin-angiotensin-aldosterone system to start, right? Good. Okay. So there are 5 parameters. Because blood pressure is so vital, regardless if you go too low or too high, there are severe consequences. Therefore, our body has created 5 parameters that will help maintain the blood pressure. Okay? So these 5 parameters are heart rate, blood volume, stroke volume, peripheral resistance, and blood viscosity. So heart rate, blood volume, stroke volume, peripheral resistance, and blood viscosity. What does blood viscosity mean?
Thickness of the blood.
Thickness of blood. Okay? So blood viscosity tells you the thickness of blood. If your blood pressure is low, all 5 of these will increase. Okay? If your blood pressure is high, all 5 of these will decrease. Good? Okay. Before we go into more in detail, we need to learn a few more terminology. So, cardiac output, CO. Cardiac output means amount of blood your heart ejects per minute. The key thing is per minute. So every single minute, how much blood is your heart ejecting? That's your cardiac output. Okay? Next one is stroke volume. Stroke volume is amount of blood your heart is ejecting in one cardiac cycle. So, stroke volume, amount of blood your heart is ejecting in one cardiac cycle. Cardiac output is per minute, stroke volume is per cardiac cycle. Okay? Any questions? Preload and afterload. So, preload is, these are just concepts. Preload and afterload are concepts to help you understand the workload on the heart. So preload is the amount of work placed on the heart due to incoming blood. So from the venous end. Okay? Where afterload is amount of work placed on the heart due to outgoing blood, meaning the arterial end. Preload is usually venous end, and afterload is usually arterial end. Okay? Does that make sense? So, imagine, let's say you guys are a nurse. Okay? You guys have 10 patients when you come in every day. You guys have 10 patients. Now, every day 5 patients should be released and you should get new 5 patients. So total you should only have 10 patients, right? Okay? Imagine one day you go to your shift, you start out with 10 patients. Okay? You discharge 5 patients, but instead of 5 patients coming in, instead of 5 new patients coming in, about 8 patients comes in. Okay? So how many patients do you have in total now? 13, right? Your workload increased, correct? Is that due to you not discharging enough patients, or is that due to more patients coming in? So would you call that preload has increased or afterload has increased? Preload. Because your outgoing did not change. Your outgoing was 5, but you got more patients coming in, meaning your preload increased. Does that make sense? Okay? Melvin?
Oh no, yeah, no,
Okay.
this is great.
Now, imagine some other day you come into work, you have 10 patients. Okay? You get 5 new patients, but instead of discharging 5, you only discharge 2. So how many patients do you have now?
3. What?
You have, when you came to work, you had 10 patients.
Discharge 2.
You got 5 new patients, okay, which is your normal number. You always get 5 new patients. But instead of discharging 5, you only discharge 2. So how many patients do you have now? 13, right? Did your workload increase? Yes. Was that due to you not discharging enough, or you're getting more patients in? Not discharging. So would you consider that your preload has increased or afterload has increased? Your afterload has increased because you did not discharge it. Does that make sense? Okay? Any questions? These terms are very important because when you go into your clinics, you always hear preload, afterload. Okay? Okay. More terminology. EDV, and diastolic volume. What does EDV mean? And diastolic volume. When diastole has completed, what is the amount of blood in that chamber? So at the end of diastole, what is the volume of blood in that chamber? That's your end diastolic volume. Okay. Next one is end diastolic pressure. So when your diastole has completed, what is the pressure in that chamber? So at the end of diastole, what is the pressure in that chamber that we're talking about? Good? Yeah. And systolic volume. What does end systolic volume mean, you guys? So at the exactly. So at the end of systole, what is the amount of blood in that chamber? That's end systolic volume. And systolic pressure is at the end of systole, what is the pressure in that chamber? Good? Did I go too fast? Okay. Any questions on this terminology? Now, there are 3 equations that you guys have to know, okay? And these equations are going to be on the test next week. You have to be able to plug in the values and be able to calculate. Just as you guys were able to do the math in the spirometer, right? I gave you a patient, I told you this is their tidal volume, this is their FC, and you had to calculate. Same concept. You should be able to do this kind of math. There will be simple math which you don't need a calculator, okay? But the proctors will bring a calculator. Okay?
Is that the one that came in last week?
Yes, because we kind of ran behind. I should have covered this in weeks 6. Therefore, it should have been in exam this week, but because we were running behind, that's why.
This is on Tuesday.
Okay, so the 3 equations that you have to know. The first one is blood pressure equals cardiac output times peripheral resistance. So cardiac output times peripheral resistance will give you blood pressure. CO times PR gives you blood pressure. That's one equation. Second equation is how to calculate cardiac output. Stroke volume times heart rate gives you cardiac output. Because cardiac output is amount of blood ejected per minute. Okay, so stroke volume gives you how much you're ejecting per cardiac cycle, and heart rate tells you how many cardiac cycles you're having per minute. So if you times those 2, it will give you cardiac output. The last one is how do you calculate stroke volume? So stroke volume is end diastolic volume minus end systolic volume. Okay? So end diastolic volume, let's say you started out with 100 milliliter. At the end of diastole, it was 100 milliliters. Okay? And once systole was complete, there's only 60 milliliters in there. So how much did you eject?
40.
So the stroke volume would be 40 milliliters. Does that make sense? Questions, concerns? Okay. Now we're going going to see how each parameter actually increases your blood pressure. What were the different parameters? What was one parameter? Give me one. Heart rate. Another one? So heart rate. Another one?
Blood volume.
Blood volume. Another one?
Stroke volume.
Stroke volume. Fourth?
Or resistance.
Peripheral resistance. Fifth?
Blood
Blood
viscosity.
viscosity. So we're going to see exactly how each parameter is increased. So we're going to just focus on hypotension right now. Okay, if your blood pressure drops. So, a gentleman was shot. They have arterial damage, so they're bleeding profusely. Because they're bleeding, their blood pressure drops, which activates the baroreceptors. Once the baroreceptors have been activated, the medulla oblongata gets stimulated, which in turn stimulates your sympathetic nervous system. And your sympathetic nervous system brings your blood pressure back up by increasing your heart rate, peripheral resistance, blood viscosity, stroke volume, and blood volume. So now we're going to see each one. Okay?
I have a question on that.
Yes?
When you say if you increase the blood viscosity, it decreases everything, right? Because if it's thick, it's slower.
But it increases the blood pressure, how much pressure. So imagine traffic as your blood pressure. Okay? Now, in traffic time, right? Why is it there's a lot of traffic? Let's say at 5 o'clock, 6 o'clock. Why is there a lot of traffic? Because aren't there more cars, right? So the traffic increased, right? So think of it that way. So blood pressure increases because you're adding more red blood cells. Okay, let's look at how heart rate is increased. So, majority of this part is going to be the same from one slide to the next, because it's once blood pressure drops, baroreceptors get stimulated, which stimulate your medulla, in turn SNS is activated. This part is usually different from one slide to the next, okay? So, sympathetic nervous system is activated, and it causes epinephrine, norepinephrine to be released. Once epinephrine, norepinephrine are released, they actually cause the adrenal medulla to release more epinephrine, norepinephrine in turn. Okay? Because remember the adrenal medulla released epinephrine, norepinephrine? Once epinephrine, norepinephrine have been released, it actually causes the SA node to be stimulated. Remember the SA node is the pacemaker. So if you stimulate your SA node, okay, it's going to fire more, correct? If it fires more, isn't your heart rate increasing? Is that your pacemaker? Okay? So your heart rate increases because you're stimulating your SA node. Good? Now, how do you increase your blood volume? The blood volume is increased via the renin, angiotensin, aldosterone system. Okay? So once your blood pressure drops, it increases renin, angiotensin, and aldosterone system, because when blood is going through the kidneys, your kidneys will detect a drop in blood pressure, release renin, activate the renin, angiotensin, and aldosterone system. We covered that in the chronology. You have to know it for next week's test as well. Okay, I'm not going over it right now because we already covered it. Questions? Now, let's see how we can increase our stroke volume. Am I going too fast for you guys? Now, there are 3 ways that you can increase your stroke volume. This is why they're in different color. So one way is the purple, another way is the green, and another way is the orange. All 3 of them will occur, but there are 3 different ways to increase your stroke volume. Okay? So let's talk about the purple one first. Epinephrine, norepinephrine are released due to activation of sympathetic nervous system. That activates all 3 of your muscle types, your smooth muscle, your cardiac muscle, and your skeletal muscle. And it causes those muscles to contract, okay? Which increases your venous return. VR is venous return. What does venous return mean? Any idea?
It's what the oxidative blood that's bringing back to bring brought back into the heart to start the new cycle.
Well, start a new cycle. So Venous return is the blood coming back to your right side of the heart. So your superior vena cava, inferior vena cava, that coming back and draining blood, starting a new cardiac cycle. Okay? You said oxygenated blood, that's wrong. It's deoxygenated blood. So once your muscle contracts, it increases your venous return. So more blood is coming back to the heart. If more blood is coming back to the heart, aren't you increasing amount of blood at the end of diastole? Remember in the last example we said 100 milliliters? But instead of 100, let's say you have 120 milliliters in your ventricle at the end of diastole. So if you have 120 milliliters, aren't you going to eject more blood out? Right? Okay? So because you have more blood returning to the heart, you have a higher stroke volume. So you're ejecting more blood out from the heart. Because your stroke volume increases, your cardiac output increases. Because your cardiac output increased, your blood pressure increased. Okay? Now imagine this is a vein. This is the water inside this bottle is the blood. And my palms are basically the muscles. Do you guys remember from anatomy, veins are usually found between the muscles. So when your muscles contract, it squeezes these veins and blood goes up. Okay? And therefore, when the muscle contracts, it causes your veins to push blood upward, meaning increase in venous return. Increased venous return, meaning there's more end diastolic volume. If there's more end diastolic volume, there's more stroke volume. So increase in stroke volume. Increase in stroke volume means increase in cardiac output. Increase in cardiac output means increase in blood pressure. Okay? So that's one way. Another way is via breathing. Remember when we were talking about breathing, anytime you create a negative pressure inside your lungs, it causes your thoracic veins to drain blood, correct? Okay? That's how the intrapulmonary volume increased. Remember from breathing, respiratory system? So that time I just said thoracic veins and I was only referring to the lungs. But thoracic veins means veins that drain into the heart as well. Okay? So when you breathe, it creates a negative pressure because the diaphragm pulls your lungs down, respiratory muscles pull it outward, causing a negative pressure. And that negative pressure causes all of your thoracic veins, the veins to the lungs as well as the veins to your heart, all of them to drain blood inside those organs. Okay. So, because increased respiration increases intrathoracic volume, meaning the thoracic veins are draining, which decreases intrapulmonary pressure, and that increases EDV. Okay, because now your thoracic veins are draining into your organs, there's more blood coming into the heart. If there's more blood in your heart, you're going to eject more blood out. If you're ejecting more blood out, you're going to have a higher blood pressure. Okay? And a last way to increase your stroke volume is to actually decrease your end systolic volume. Meaning, you want to decrease how much blood is remaining in your ventricles at the end of systole. Okay? So when sympathetic nervous system has been activated, it causes epinephrine, norepinephrine to be released. Epinephrine, norepinephrine in turn binds to your myocardium, the muscle that actually causes contraction of the heart. Once the myocardium has been stimulated, it increases contraction. So there's a more stronger forceful contraction. And if there's a stronger forceful contraction, you're ejecting more blood out. Okay? If you're ejecting more blood out, isn't there less blood remaining in the chamber at the end of systole? So you have just decreased your end systolic volume. So remember in the example I said, that you start out with 100 milliliters of blood. At the end of systole, there's 60 milliliters left. So how much did you eject out? 40. Okay, 40. Now, you have 100, but instead of ejecting 60, you eject 80 milliliters. So how much blood do you have left over at the end of systole?
20.
So do you see your end systolic volume decreased? And how did you cause your heart to eject more blood? Not 60, you actually caused it to eject 80 milliliters by actually causing your heart to contract stronger and harder by stimulating the myocardium. Good? Stroke volume is the hardest one to memorize. Okay? This is the most complicated one. Okay, peripheral resistance. There's two ways to increase your peripheral resistance. Okay? So epinephrine, norepinephrine are released, which activates your alpha receptors in your arterial walls. The alpha receptors cause calcium to be released. Okay? Now, your smooth muscle, okay, your vessels are smooth muscle, correct? So, if calcium is released, what is the importance of calcium in smooth muscle contraction? Come on, you guys. What is the importance of calcium in smooth muscle contraction? It binds to comodulin, activating comodulin. It actually, comodulin now activates myosin light chain kinase. Myosin light chain kinase activates the myosin, so thick and thin filaments can bind and sliding filament theory can occur, correct? So, by activating your alpha cells in your arterial walls, you cause calcium to be released. Calcium will bind to your smooth muscle, causing it to vasoconstrict because you just basically caused your smooth muscle to contract. So vasoconstriction leads to increase in peripheral resistance. Okay? And if there's increase in peripheral resistance, there's an increase in blood pressure. Okay? Imagine the freeway. Right now, okay, it's what? 3 o'clock, okay, and there's no traffic, okay? It's going pretty smooth. If I decrease the lane, so right now, let's say 10 East has 4 lanes. If I make that into 2 lanes, what happens to the traffic? It gets congested, right? What happens to the number of cars? It looks like there's more, right? And therefore, the traffic increased, right? Same concept. When you vasoconstrict, your peripheral resistance increases, okay? And therefore, the blood pressure increases. Does that make sense? So that is one way to increase your peripheral resistance. Let's decrease the diameter of your vessel. A second way is to do blood viscosity, to increase your blood viscosity. So how would you increase your blood viscosity? How would you place more red blood cells in your blood? Erythropoiesis, right? Wasn't erythropoiesis causing your red bone marrow to produce more red blood cells? Okay? So how do you increase blood viscosity is to undergo erythropoiesis. And because now you're placing more red blood cells in your arteries, your blood is thicker. And if your blood is thicker, your blood pressure increases. So peripheral resistance is increased by decreasing the diameter of the vessel plus increasing the blood viscosity. Okay? Now, erythropoiesis, I'm not going to go over, but you are responsible to know it for next week. Okay? And if you guys remember, blood viscosity was another parameter by itself. Okay, question 1. Okay, so which one do you guys think it is? Good. I'm waiting for the students to answer. The students who are watching at home, try it at home. Okay? Yes.
Okay.
Yeah, I understood that. I can't see that, just write it big. Okay. It's E. Okay? Pulse is not the one that would increase. Question 2.
That's
No.
the same thing I said.
Okay,
It's not.
yes. So the answer is D.
Can you explain that one?
Sure.
Oh.
So I said one of the treatment regimen is to administer a drug which causes vasodilation of your arterioles. What did I say? Preload is associated with your venous end, and your afterload is associated with your arterial end. Arterioles are your arterial end, right? So if you dilate your artery, what happens to the blood pressure? It drops, right? Correct? If I expand the freeway, doesn't the traffic decrease? Right? So if you decrease the blood pressure, then doesn't your heart have to work less? So instead of creating 120 millimeters per mercury, if I drop my blood pressure to 90 millimeters per mercury, doesn't your heart only have to generate 91 millimeters per mercury to open up the aortic valve? So the afterload has decreased. Does that make sense?
So if it was the vasoconstriction, then it would cause the afterload to increase?
Perfect. So if there was vasoconstriction, okay, your afterload would increase because vasoconstriction would cause your blood pressure to go up. So instead of 120, it would become 130. And now your heart has to eject, or it has to get 131 millimeters per mercury to open up the aortic valve. Therefore, then your afterload would increase.
What would it be called if it was preload?
So it would have to do with the
It would have to do with the vein. So let's say hydrolysine is actually a drug that dilates your venous ends. So that would actually cause what?
preload to decrease.
Preload to decrease because you just dilated your venous end. What happens, let's say you eat a bag of salty chips. Okay? What happens? Think.
Constrict.
Huh?
You're moving to constrict.
So if you eat a bag of salty chips, would your preload be affected, your afterload be affected? Preload. Your preload would be affected. Would your preload increase or decrease?
Increase.
Why would it increase?
Because you're constricting the water.
You're not vasoconstricting.
You're dilating.
You're dumping more blood into your veins. Because you're eating a bag of salty chips, you're going to retain the water. The golden rule, wherever sodium goes, water follows. So now you're dumping blood into your venous end. So now more blood is coming into the heart, causing an increase in preload. Okay? Okay. Please calculate the stroke volume.
Stroke causes stroke. I'll give it a reading.
Yes, so the answer is D. So it is 100 minus 40, which is 60. Okay? Next question. Good. Good.
So 560. Or 400. So it's one.
Oh, so it'll be 60 times 8.
Yeah, 60 times 80.
Okay, so the answer is A, 4,800. How? What was the equation for cardiac output?
Equals stroke volume
Stroke volume
times
times.
HR.
Yeah.
So what was stroke volume?
60.
What was HR?
80.
Which will equal 4,800. Good? Okay. Any questions on this chapter, on this section? No? Okay. This will be on the exam next week. So next week your exam is going to be on the hemostasis, primary and secondary hemostasis. It's going to be on the entire immune chapter and plus this blood pressure. Okay?
Ouch.
You can turn it off.